All right, let's get straight into it. We're appraising the second asymptomatic carotid surgery trial, ACST2. This is a paper that's almost certainly going to come up in the academic viva, so we've got to break it down just like we would for the examiners.
So I'll structure my appraisal in 6 parts. We'll start by framing the question using PICO. Then I'll assess the internal validity by looking at the methodology. We'll take a close look at the statistics, then focus on the key results. After that, we'll discuss applicability and limitations, and I'll conclude with a final verdict.
Okay, so first, let's frame the clinical question using the PICO framework. This really helps us deconstruct what the trial was actually asking.
So, the population. We're looking at asymptomatic patients who had a severe carotid stenosis, typically defined as 70 to 99%. And the crucial point here is that these were patients for whom the treating clinician judged an intervention was necessary, but there was genuine clinical equipoise between stenting and endarterectomy.
Right, and the intervention arm was carotid artery stenting, or CAS. It's important to note this was performed by experienced operators who were mandated to have low complication thresholds. They were using contemporary devices and, of course, standard dual antiplatelet therapy. The comparator, then, was carotid endarterectomy, or CEA. Again, this was performed by experienced vascular surgeons, with the protocol allowing for optional shunting and patching. And just like the intervention group, these patients were also on contemporary best medical therapy.
And finally, the outcomes. The primary outcomes were twofold. First, they looked at the procedural risk, specifically any death or disabling stroke within 30 days. Second, they assessed the long-term risk of non-procedural stroke, with a particular focus on fatal or disabling strokes over a mean follow-up of about 5 years.
Okay, so having framed the question, I'd now like to move on to the trial's internal validity, really getting into the nuts and bolts of the methodology and how robust the study architecture is.
Fundamentally, this is a large, international, multi-center RCT, analyzed on an intention-to-treat basis, which is exactly what we want to see. But a few methodological points are worth highlighting. They used a minimization strategy for randomization. They had masked outcome adjudication, and there was mandatory credentialing for all operators. The follow-up was a mean of 5 years. Let's look at a few of those in more detail.
So, the randomization strategy is particularly interesting. They used minimization, not stratified randomization. This is key because while it balances known patient characteristics across the 2 arms, they specifically didn't stratify by center. This is a strength because in smaller centers, stratification can make the next allocation predictable, which could introduce selection bias. Minimization without center stratification avoids that problem.
Now, of course, in a procedural trial like this, blinding of the operators and patients is impossible. However, the investigators took a crucial step to reduce bias. The outcome adjudication for non-procedural events was masked. This means the committee reviewing potential strokes didn't know the patient's allocation, which is a powerful way to reduce detection bias.
And a quick word on the follow-up. A mean of 5 years is certainly adequate for assessing the primary midterm stroke outcomes. That's not in question. But, as a point of criticism, it is insufficient to really tell us anything about the lifetime durability of either the stent or the endarterectomy. That question remains unanswered.
Right, let's move on to the statistical analysis. I think interrogating the analytical methods is key to properly interpreting the results.
So, there are 3 key statistical points. First, the analysis was correctly performed on an intention-to-treat basis. This is absolutely essential in a procedural trial where you expect some crossover as it preserves the integrity of the randomization. Second, for the non-procedural outcomes, they used Kaplan-Meier survival analysis to plot events over time. And third, they used log-rank testing to compare these curves.
Okay, this brings us to the headline statistic for any non-procedural stroke. The paper reports a rate ratio of 1.16, with a 95% confidence interval of 0.86 to 1.57 and a p-value of 0.33. Now, let's unpack that.
The critical value here, of course, is 1.0. That represents the line of no difference. A rate ratio of exactly 1 would mean the event rates in both groups were identical.
And as you can see, the 95% confidence interval, which runs from 0.86 up to 1.57, clearly crosses that line of no difference. Therefore, we have to conclude that for the outcome of any non-procedural stroke, this result is not statistically significant. We cannot reject the null hypothesis.
So, having looked at the statistics, let's turn to the key clinical results, the ones that are most significant for an examiner.
Looking at the procedural events within 30 days, the most important finding is that the rate of disabling stroke or death was very low and similar in both groups, at about 1%. But below that, there was a clear trade-off. The stenting group had an excess of non-disabling procedural strokes. Conversely, the endarterectomy group had an excess of myocardial infarction and perhaps most notably, cranial nerve injuries, which occurred in over 5% of patients versus 0 in the CAS group.
And for me, this is perhaps the single most important result of the entire trial. If you look at the 5-year rate of fatal or disabling non-procedural stroke, the outcome we're all most concerned about, the rates were identical. They were approximately 2.5% in both the CAS and CEA groups. That's a very powerful finding.
So, with those results in mind, how does this translate to clinical practice? This brings us to the trial's external validity, its applicability, and of course, its limitations.
Well, there are several key limitations here. First, generalizability. These outcomes reflect expert, high-volume centers, and we can't assume they apply everywhere. Second, and this is critical, the trial does not compare intervention versus best medical therapy alone. In an era where modern medical therapy has driven the absolute stroke risk so low, that's the real unanswered question. And just to note, there was no health economic analysis and no routine imaging surveillance in the long-term follow-up.
All right, to conclude, I'd like to offer my final verdict on the trial, synthesizing these points into a conclusion suitable for clinical practice.
So, my summary statement would be that this is a practice-informing trial, but it is not a practice-changing trial. It provides crucial data, but it doesn't fundamentally alter our approach.
So, to conclude, ACST-2 is a methodologically robust trial of high academic quality. It supports the position of equipoise between carotid artery stenting and carotid endarterectomy, but only in carefully selected asymptomatic patients, and crucially, only when performed by experienced operators with proven low complication rates. It absolutely does not justify expanding our current intervention thresholds, nor does it justify replacing endarterectomy as the default therapy. For its internal validity and academic quality, it warrants a pass.